Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Shabana Shahid. Today I'm going to talk about the MLL KMT2A gene rearrangement in acute leukemia. As you know that so too much is going on with NGS, whole genome sequencing, we talk about it. But unfortunately, I took the data of 300 acute leukemia newly diagnosed patients, and only 10 patients were able to afford NGS. So it's hopefully cost will come down, quality will get better, diagnostics will get better, and every patient will be able to get it done. So being a hematologist and section head cytogenetic lab, I come across that what should be done with the patient. I need to explain it to the physicians that it is high risk, low risk, what to do with the patient. So let's start with my talk. Before I come to the topic, I want to share one case with you. I had a patient, 47-year-old female, and she was diagnosed as precursor B acute lymphoblastic leukemia in April 2021. So her cytogenetics were done, which were normal, BCR, ABL, FISH were normal, ALL gene panel was normal. So everything went well. After post-induction chemotherapy, she was in remission, and on the maintenance chemotherapy, that is post 3 cycles of hyper-CVAD, she was in remission, so everything was fine. And then she was on maintenance therapy on outside institute. But in August 2023, she presented with pancytopenia, so we decided to do the bone marrow biopsy to see the relapse status. So bone marrow biopsy showed disease relapse with 70% of the blast. So after looking at her discussing in MDT, we were discussing that what has been missed. So MLL FISH was missed in her investigations. So for FISH, I need peripheral blood or bone marrow sample, but the peripheral blood was, she had pancytopenia, total leukocyte count was very low. So, of course, bone marrow biopsy is an invasive procedure and I couldn't repeat it. So what we did is we decided to do the FISH MLL gene rearrangement on paraffin embedded plot section after doing TDT and PAX5 plot section. So FISH was positive for MLL gene amplification. As you see here, this one is normal, that is 2 fusion signals, and this shows 4 fusion signal pattern. So this patient showed MLL gene amplification. So too much data is coming on MLL gene amplification. That is more than 18 years of age. It shows the high risk group, and this should be patient should be monitored closely. Unfortunately, after a few weeks, this patient expired. So I think that it could have been managed better. With this, I start with the main topic, that is the MLL gene. What is MLL gene? This MLL gene or KMT2A gene is present. It is located on chromosome number 11 at position 11q23. And this gene, also known as KMT2A, is crucial for maintaining the normal hemopoiesis. It encodes for a histones methyltransferase, which regulate gene transcription, including a Hox gene. Now, what happens when MLL gene rearrangement occurs? It leads to the sustained Hox gene expression, which leads to the stalled differentiation of the myeloid cells, of the lymphoid cells, normal maturation, normal hemopoiesis is totally halted, and it leads to the sustenance of the blast cells in the marrow and peripheral blood. So coming to the study, keeping in view the MLL gene alterations by assessment by FISH, it was to report the frequency of MLL gene alterations in patients with acute leukemia and to assess the impact of acute leukemia gene alterations on the patient outcome. So it was a retrospective cross-section study. We did 3 years, data collected. Study was conducted at Shifa International Hospital, and the age range was 2 months to 66 years of age, male to female ratio 2:1, and only the newly diagnosed patients who did not receive any sort of chemotherapy were included in the study for FISH for MLL gene rearrangement only. And exclusion were those who have received chemotherapy or other than MLL gene rearrangement were excluded from the study. So we studied total 167 patients of acute leukemia, which included the acute myeloid leukemia, acute lymphoblastic leukemia B and T, and the positive cases turned out to be 25, which is 15%, with 11 cases showing the gene rearrangement, that is the break apart signal. More than 2 fusion signals were seen, gene amplification was seen in 11 cases, and 3 cases showed only the MLL gene deletion, that is the only one fusion signal. And this is just the representation by the pie chart of what I've said. So disease-wise positivity, it was most commonly seen in the precursor B acute lymphoblastic leukemia, followed by AML, and then the precursor T acute lymphoblastic leukemia. So talking about the clinical impact of the positivity of the different signal patterns. So this break apart signal, it was most common in AML, and it showed one patient was able to make up to the hematopoietic stem cell transplant. One patient expired, and positive MRD, we had 2 cases, and then 55% of the patients, that is almost 6 patients, we lost follow-up. So looking at the gene amplification, it was most commonly seen in the precursor B acute lymphoblastic leukemia, that as shown here, it is showing the 4 signals. We had multiple signal patterns like 3 fusion signals, 4 fusion signals, up to 6 fusion signals, but overall impact was not different in gene amplification. One patient could make up to the hematopoietic stem cell transplant, 1 patient expired, 2 showed disease remission. MRD was persistently positive in 2 patients, and almost 4 patients lost follow-up. MLL gene deletion, we had only 3 cases, and the overall, if you look at the literature review data, is still scarce. But the all cases, 2 cases shows MRD positivity, and 1 case lost follow-up. So we know that this MLL gene has multiple gene partners. They have 73 recurrent translocations and 54 partner genes. So getting hold of PCR of each and every translocation is not possible. So FISH is a very good tool just to judge whether the MLL gene is rearranged or not. And there's so many data coming up that FISH improves the risk stratification in acute leukemia by identifying KMT2 abnormal copy number or rearrangement. This is a very good study which is published in Nature. They studied the 269 patients, and side by side they did the RT-PCR, and they showed that FISH is a very good tool in assessing the overall FISH, the MLL gene rearrangement pattern. So 10% of human leukemias, that is AML, precursor T, acute lymphoblastic leukemia, B acute lymphoblastic leukemia, showed harbored the MLL gene rearrangements, and overall they showed the unfavorable outcome. Only 2 patients had the MRD negativity. Otherwise, most of the patients either expired or persistently MRD positive by flow cytometry, or the most of the patient relapsed. This is another study which is showing that MLL gene amplification, it is associated with the elderly patients, TP53 mutations, complex karyotype, aggressive clinical course, poor response to chemotherapy, and extremely short survival. And this is another literature review which is showing that a lot of going on with the treatment modalities. And in this, this is a very good paper which is showing that new treatment modalities are urgently needed. DOT1L inhibitors, they were studied, but which showed that according to literature review. I'm just leading to the conclusion. So the most promising drug based on literature review was also failed. So there is another study which is showing that IRAC inhibitor was used to block the degradation of endogenous MLL, but still a lot of studies going on. So coming to the take-home message, FISH is an important tool to detect the MLL gene rearrangement and copy number variables. And MLL gene rearrangements, including gene amplification deletion, shows poor outcome. And scarce data is there, especially if we look at the MLL gene deletions. More data is required for the treatment modalities. Blinatumomab is tried here, but it has failed also. So MLL is important, and it can be easily detected by FISH. Thank you.
Thank you. So we don't have time for questions. So let's skip to the second paper. Dr. Saida. Is Dr. Saida being Zahra?
She's online.
She's online.
How much time does she have?
Can we connect?
10 minutes?
Assalamualaikum. I'm Sayyida Amin Zara, Supervisor Medical Scientist from Satellite Department of Indus Hospital and Health Center. Today's my topic is the chromosome 1 abnormalities in childhood lymphoblastic leukemia analysis and analysis with reference to the clinical variables and survival outcome. The most common cytogenetics and the most common childhood cancer in acute lymphoblastic leukemia ALL with 80 to 85% of cases coming from the beginning age. Childhood lymphoblastic leukemia BLL usually has good prognosis with cure rate approaching 90% in high income countries. The study of chromosomal abnormalities in one is one of the essential components in understanding the genetic basics of ALL. A number of recurrent chromosomal abnormalities define genetic subtypes of ALL that are associated with a specific clinical outcome. The abnormalities of chromosome 1, which is the largest human chromosomes, are commonly reported in hematological malignancies such as multiple myeloma and myeloid malignancies. A variety of structural and numerical chromosome 1 abnormalities are described in this hematological disorders with reference to clinical features and diagnosis. Today, the objective of my study to evaluate the significance of chromosome 1 abnormalities with reference to clinical characteristics and survival outcome in pediatric lymphoblastic leukemia cohort. This is the retrospective observational and non-therapeutic study conducted in the cytogenetic section of clinical laboratories of Indus Hospital and Health Network. Data of all patients reviewed from 1 to 16 years of age who were diagnosed with the BLL. In fertile leukemia cases, average age less than 1 year were excluded from the analysis. The diagnosis was confirmed by the immunophenotypic using flow cytometric analysis of bone marrow spirates or blood samples or immunohistochemistry on bone marrow biopsy. Data retrieved from October 2020 to July 2020 for childhood BLL cases exhibiting chromosome 1 abnormalities. For chromosome analysis, bone marrow aspirate samples collected in sodium heparin were used and unstimulated cultures for 24 hours were set up. After culturing, macrophages were arrested by consummate and treated with hypotonic solution. This was followed by the fixation using carnitine filter. After fixation, slides were made and DTG bending was performed. By using cytovision MD8, total 20 GTG banded cells, metaphysis cells were analyzed. Results were recorded according to the International System for Human Cytogenetics Nomenclature (ISCN 2020). Data was analyzed by using SPSS, bone marrow SPSS version 24.0. Descriptive statistics like median, interquartile range were computed for age and white cells count as appropriate. Frequency and percentage were calculated for qualitative variables such as sex, central nervous system status, prednisol response, various cytogenetics aberrations, and disease outcomes. Chromosome 1 abnormalities was observed in 60 out of 450 cases of BLL, depending on the types of the aberration. Chromosome 1 abnormalities were broadly stratified into 4 categories, including cases with translocation 119, 1q duplication with hyperdiploidy, complex karyotype with chromosome 1 abnormalities, and non-specific chromosome 1 abnormalities as shown in this figure. Among chromosome 1 abnormalities, 29 cases had translocation 1 abnormality. that there were 13 balanced and 16 unbalanced translocations. 1Q duplication with hepatitis was shown in 14 cases. Complex karyotype with chromosome 1 abnormalities were in 9 cases, and non-specific chromosome 1 abnormalities was in 8 cases. The aberration without the median age for chromosome 1 abnormalities with or without translocation 119 was 8 years and 6 years, while the median leukocyte count was 32 and 17 respectively. Event-free survival for cases with and without translocation 119 was 69 and 74.2 respectively. Cytogenetics abnormalities such as chromosomal structures, arrangements, and aneuploidies are the most common findings in the childhood PLL and observed in approximately 70 to 80% of the cases. In our retrospective analysis, chromosome 1 abnormalities were observed in 13.3 cases of BLL. Although overall incidence of chromosome 1 abnormalities have been commonly reported in many adult onset hematological malignancies, including chronic myeloproliferative disorders and multiple myeloma, where there is a paucity of data for childhood care. However, there are studies on specific chromosome 1 abnormalities such as translocation 119 and 1Q duplication in child. The two most frequent observed chromosome 1 abnormalities in our cohort were translocation 119 and duplication 12 with hepatophily with prevalence of 49% and 23% respectively. The overall occurrence in their cohort was 6.4% aberrations and translocation 1 aberrations and 3.1% of for duplication 1 with hepatophily, both of which were found to be comparable to previous data. The category of 1P duplication with hepatocyte has 14 CNS positive cases in our cohort. The influence of translocation 119 on CNS involvement yields contradictory results. The translocation 119 positive group was further classified as having balanced or unbalanced translocation. So statistically insignificant, there was a difference in survival with 54% EFS patients with balanced translocation and 81% of individuals with unbalanced translocation. There were more unfavorable clinical features in translocation 119 patients, such as higher median age, a higher white cell count, and more CNS positives. However, the EFS was compared in both the translocation 119 positive and negative groups. Similarly, no negative association was found in between 1Q duplication and EFS. A difference in survival between notifications noticed between patients with balanced and unbalanced translocation. Also statistically insignificant, these results are still preliminary and require further large-scale prospective study to gain more insight. Thank you.
Okay. Any questions? I think we have one minute left. Any questions?
Yeah, any questions very quickly? I just want to sort of, Ambereen, thank you so much. We know that you originally had planned to travel to Lahore, but because Indus had a CAP audit, you were stuck with that for this whole week, and yet you still found time to prepare for this presentation. So we're really, really grateful for you, for joining us online and presenting your work. Thank you. Over 4 decades of experience in leading research at various Tier 1 academic and non-academic institutions in the United States. So I'd like to welcome Dr. Sohail Rao. The stage is all yours, sir.
Assalamu alaikum. Good evening. I think it's actually quite evening over there in Lahore. Thank you very much for giving me the opportunity to participate. Everything that I'm going to talk this evening or this afternoon is actually my last 5 years of experience in working as the chair of the University Scientific Board at the Dow University of Health Sciences. I also serve as the chair of the Doctoral Admission Committee there, and also is the senior advisor to the Vice Chancellor. So I have actually practical experience of trying to enhance clinical research in Pakistan. So some of the things that I'm going to talk to you today actually have evolved from my own interactions. And it's actually, I have taken a slightly different approach, and I hope you don't mind, because what I have decided to do is to identify what I consider to be barriers in enhancing investment in clinical research and in translational research in Pakistan, and how those barriers could be overcome. So if you don't mind, I'm going to share my screen with you. Can you see my screen?
Yes, sir.
So obviously I was given the task to talk about bridging the gap and trying to enhance the investment in research in Pakistan. The word investment, in my mind, is not just financial, it's also investment in terms of infrastructure, investment in terms of enhancing the hard skills of people in Pakistan, their ability to actually conduct appropriate research, their ability to understand compliance and safety. So it's investing in a much broader sense that I am using. So I just want to start by saying that how lucrative clinical research is, or R&D expenditures are for science and engineering globally. And we're not talking about millions of dollars over here or even billion dollar. We are actually, here are the top 8 R&D performing countries as of 2023. And if you, the two top are actually United States and China. The total funding for in 2021 was about $1.9 trillion. I repeat, $1.9 trillion were actually the amount of funding that was in for both science and engineering. And the United States and China actually had the major share, about $1.3 trillion. If you look at who is funding this, it is actually industry. 75% of the funding actually is provided by industry. And it is important to understand and keep that in mind as we move forward in this conversation that we are having. If we then actually go and do a little bit more deeper analysis and ask ourselves, what is industry funding? And you will realize that 60% of the funding from the industry is actually going into health sciences, one form or the other. It could be very basic research to very clinical phase 1, 2, 3, and 4 research. So 60% of $1 trillion, which is about $600 billion, industry is actually pumping into health sciences research. Engineering is getting about 30%, and other are getting about 10%. So this particular slide actually highlights the importance of actually paying not only attention to industry-funded research, but the fact that the industry is the primary source of funding for research, for R&D expenditures. If you then ask yourself, okay, in health sciences, what are they funding? Are they funding just the basic research? Are they funding a translational or clinical research? And you realize that 20% of the funding from the industry is actually going into, this is about $600 billion. 20% of that is going into basic research. About 30% is going into translational research, but the bulk is actually going into clinical research. In fact, 80% of the funding that R&D does, that industry does in health sciences, is actually going into one or the other form of clinical research, whether it is translational from bench to bedside, or whether it is from bedside to bench, and half of it is going into pure clinical research. Now, let us look at Pakistan, what is happening. And this is unfortunately the latest data that I could get, published data that I could get about funding for health research funding in Pakistan. And in essence, in the last 5 years, from 2013-14 to 2017-18, we have invested about $4.6 million in research. This is breadcrumbs as far as what is available, potentially available to actually bring to our country to help our community and our the disease burden that we exist. Now let's look at similar pattern in India. And India, this, by the way, is entire R&D expenditures. This is not just health sciences. And it has been in the last reported, which was actually part of the National Science Foundation reporting, was that they have actually $63 billion that are actually going into R&D. Now, clearly we are not comparing apples with apples here because I do not know what additional R&D funding happens in Pakistan because the data is sparsely available. But I can tell you with a certain degree of confidence that it is not the same as what the neighboring countries or other countries are investing in R&D. Now, so the take-home message of this is that whatever we do, we have to focus on industry-sponsored research. Okay, and we have to satisfy industry standards if we are going to actually bring more investment into clinical research, into translational research in our country. And that's the take-home message here. Now, how are we going to enhance this clinical research activity and the delivery of evidence-based medicine in Pakistan? So there are clear advantages for us for pharmaceutical companies to actually do translational clinical research in Pakistan. There is a large research-naive patient population in Pakistan. There is a heavy burden of communicable and non-communicable diseases. It's an ideal for population health research, particularly longitudinal population health research, because in Pakistan, people do not move too often, unlike that in the United States. And it becomes very easy to actually do population health and do vertical and horizontal longitudinal analysis. And last but not the least is that it's relatively cost effective. Now, I can tell you that in 2019, I tried to take one of the NIH-funded study called Preventable into Pakistan. And and I was the PI of that particular study. It's a $93 million study in which 18 centers in the United States were involved, and ours was one of them. And I tried to actually create a satellite in Pakistan and had a tremendous difficulty to the point where NIH decided that they do not want to proceed any further. And I'll share with you what those limitations were and how and the things that we have to focus on as we move forward. So the question then arises, why are we not able to, despite of all these advantages, why are we not able to actually attract the attention of international industries to actually conduct research in Pakistan? So there are 6 critical factors that I feel are important if we are going to attract the attention of industry to work with us in Pakistan. And I will share those with you. And by the way, these factors are actually as much applicable to institutions here in the United States as they are to any international institution. The first is that you have to have access to patients and data. You have to have, obviously, EMR. You have electronic medical record. Majority of the institutions, and you will see that what I will share with you. The second is that you have to have qualified investigators in research workforce. Individuals who have not desire to do research, clinical research and translational research, but have documented evidence that they have done clinical research. Now the question then was asked, well, how are we going to get there, because we are investigators do not have that experience. And one of the ways in which we do here in the United States is that a seasoned investigator like myself would become a sub-PI in a particular study, giving reassurance to the industry partners that this particular individual has some mentor who's going to be working with them in this particular process. The third is that you have to have a streamlined protocol review and approval process. This is one of the major reasons why the preventable study it was difficult to take it to Pakistan, because the process for getting protocol review and approval was so arduous that NIH just gave up. You have to have adequate infrastructure. Now, some organizations in Pakistan have adequate infrastructure, but everything is relative. They are looking at their infrastructure and comparing it to other institutions within Pakistan. The reality is that you have to compare yourself with a similar institution or comparable institution in a developed country. You have to have timely recruitment of patients. If you commit to recruiting 100 patients, you recruit 100 patients and you have a timely recruitment. But last and not the least is the quality of the data that is being provided has to be outstanding. Remember why the industry is actually funding. Billions of dollars is actually in the pipeline for each molecule or a device that they have. And they want FDA approval for that particular device or for that particular molecule, and they have to have a verifiable data. So these are the 6 critical factors. Now let me tell you, frankly speaking, this is also the reason why clinical research in the United States is moving more towards community health centers and towards independent research institutes, because academia do not understand how industry works. Their processes are very arcane, they are living in a dinosaur age. They have a very slow process of getting things done, and the industry does not have the patience nor the time to actually wait for them to get the protocol approved or to provide verifiable data. So let us look at each one of them, and I'm using this particular forum to actually share with you what my own experience has been and how using the intelligence and the influence of people around the table to actually see if we can actually bring about this change. We have a poor access to patients and data. The first and foremost that we have over here is that we do not have a very good patient education platform. So patients are not well informed about research, and they are also not well informed about evidence-based clinical care. And this has to start with the provider, i.e. the physician, and that's where we are having some of the limitations. There is very minimal utilization of electronic medical record in clinical environment in Pakistan. Even those institutions which actually have EMR are actually not fully utilizing it. They are still paper-based, and that creates a problem in conducting quality research. We have poor development and utilization of the data ecosystem in Pakistan. There are no data warehouses, very poor interconnectivity between the various data systems that exist, and that also creates a serious limitation. There is no longitudinal registries of communicable and non-communicable diseases that we can actually go and tap into and do some feasibility studies. And there's also, as I said, it's difficult to do feasibility analysis in a timely fashion. And last but not the least, we have poor interface with sponsor research databases for real-time synchronization. Even today, some of the studies that are happening in Pakistan, they are actually faxing or sending PDF document of research database of treatment data. And that creates a little bit of a problem for organizations here in the United States. The next one is lack of experienced investigators and research personnel. And this is important because generation of new knowledge is not a top priority for many clinicians in Pakistan. And this is where the differentiation happens between those who have a documented evidence of actually conducting research versus those who are pure clinicians. Evidence-based medicine is not universally practiced. in many institutions in Pakistan, there is no formal or systematic way to train physicians to be critical thinkers. And clinical research is an art, and you have to actually indulge yourself in clinical research to fully understand and appreciate what it actually means. And again, there is no formal process to train the research personnel in areas of compliance, safety, data integrity, and so that creates a serious barrier for conducting research in Pakistan. So when I was talking to a company called Novartis, which actually has a new lipid-lowering drug, which they wanted to actually test in individuals in Pakistan. We are going to be we were one of the satellites for them when I was at DHR. I wanted to have Pakistan be a satellite site, and they actually just outright refused. They said that we do not have, the word that was used was that we do not trust the information coming from investigators in that country. The protocol review and approval process is extremely arduous. There is a variable level of understanding of the role of IRB and it's in various institutions. Many IRBs have become scientific review boards, and that is not the role of the IRB. The role of the IRB is protecting the patient and the patient's information related to the patient. And if you see the protocol that was submitted for preventable in Pakistan, majority of the response, and this was, by the way, an NIH group study. The protocol was approved by 2 commercial IRBs and also by the IRB, by the NIH, and yet the IRB in Pakistan came back with 4 pages of concerns about that particular protocol. There are inexperienced members of the institutional review board. They have not been given the trained how to actually review protocols and provide consent forms and provide a reasonable response. There is very onerous process of intramural review and approval of protocols. It has to go through various committees before it actually gets to the IRB. And then I am still unclear as to what is the role of Drug Regulatory Authority of Pakistan, which has to review each and every protocol. And agency sitting in Islamabad is actually reviewing protocols that are going to take place in a distant city in Pakistan. It is just inexplicable to me. And I have difficulty in explaining that to sponsors here in the United States. Inadequate research infrastructure. We have poor infrastructure as far as the safely storing and dispensing investigational products. This was actually one of the areas of concern that was raised by Novartis, that this particular drug has to be dispensed in a particular way, and what would be the research pharmacy requirements in that institution. And unfortunately, the documentation provided by that institution did not satisfy the investigators here in the United States. We have inadequate clinical space to conduct meaningful phase 1 studies. Until or unless we don't start doing phase 1 studies in Pakistan, it is going to be absolutely impossible to some extent in bringing phase 2 and 3 studies in that country. So we need to actually start thinking about creating phase 1 study clinical trial units in Pakistan. We have done that at Dow University of Health Sciences, and hopefully that's going to open up the floodgates of bringing some studies to the country. We have inadequate space and capacity for optimal acquisition, processing, and international shipping of biospecimens. We actually did a biorepository study, and I can tell you that by the time the shipment of those 7 samples arrived in the United States, the samples were discarded because they were not either processed properly, or the packaging was such that it did not sustain the 6 days of shipping from Pakistan over to United States. poor utilization of EMR for recruiting and monitoring research subjects. As I said previously, EMR or electronic medical record is crucial. And if we are going to compete with international research entities, we have to start using EMR for not just for patient care, but also for research purposes. And there is no longitudinal annotated biorepository of specimen from patients. There are patches of biorepositories here and there, which are some of those samples are not annotated, and so there is really no value of those particular samples if we do not know what the pathology was, what the course of the disease was of this person, and what were the demographics. One of the areas that was raised by a very large CRO, which is PPD in the United States, actually it's in multiple countries, was that they had the experience in at one institution in Pakistan where they had a delay in the completion of the study and related milestones. There were missed patient visits and deadlines, so there was an inordinately high incidence of SEAs and AEs, and they attributed this to the lack of experience of the investigator and the research staff. There was lack of patient compliance with study protocols, and then there was high rate of loss to follow-up. And that was one of the reasons why they had to pull that particular study, PPD had to pull that study from the two institutions in Pakistan. Now, these are real reasons why we are actually having difficulty in bringing more investment, both in terms of studies, both in terms of improvement in infrastructure, in terms of knowledge and know-how to Pakistan. So I would, in the end, I would just like to remind myself, more so than the audience, is that there are solutions to all these challenges. None of these challenges that I have raised actually do not have a solution to them. We just need to systematically address them. And that has been one of our biggest hurdle, is that when we start to address one of the issues, they say, well, this is how we do things in Pakistan. Well, Pakistan is not living in isolation. Pakistan is very much part of the global community. And if we are going to compete with the global community, we have to start thinking like them. And the only way to lead is to actually change the way we behave. And I keep on reminding myself when I am in Pakistan at Dow that we need to actually bring about a cultural change in the way we actually approach these issues. I would like to thank you for giving me this opportunity, and if anyone has a cell phone, they can actually look at this QR code and connect with me if there is any need for discussion. Thank you, and I'm going to stop sharing and make myself available for any question that you might have.
Thank you very much, Dr. Rao, for the great presentation. And a lot of poor and bad that we have in Pakistan, identified it. I hope we will work on it and make it better. So if there is any question in the audience from Dr. Rao, please ask the question.
If you could come up here or to Dr. Said's mic, if you'd like to ask a question.
I would just,
sorry.
can I just add one thing? Dr. Amir Asin just prior to me gave his talk, and Amir and I are actually working very closely. We have actually set up a entity called InnovoCore Center for Research and Biotechnology, and our goal is to actually bring these resources to Pakistan. That is actually one of the areas of focus that both of us have. How can we improve and invest in clinical translation clinical research in Pakistan? I just wanted to make sure we say that.
So, Dr. Sohail, I think it starts with building trust and building relationships that are based on trust. And I think many of us here who have undertaken collaborative research with investigators abroad have had mixed experiences. today is not the forum to share that, but you know, there are lots of different you know, components of this problem, as you've highlighted. And it will start with talking about it and developing a relationship and having, you know, a two-way dialogue where we have equity. You know, I think part of what we feel in Pakistan is that whatever research we get involved in, it has to be equitable. The benefits have to be equitable and shared, and that not just for the institutions that are doing the research, but actually for our patients that are actually involved in this research. So, you know, I mean, I'm involved in the bioethical side of things as well, and so is, you know, Dr. Rana is here. She served on as chair of the IRB at SIUT. So we're all very familiar with some of the challenges that IRB members have, but it's getting better. I think we're moving towards, you know, stronger IRBs that have a better idea of how to evaluate research. And you know, I think we will get there, but it's great to have had you speak today so that we can actually initiate a dialogue. And if anybody in the audience would like to contact Dr. Sohail directly, his information was there on the screen. But yeah, Dr. Said.
Dr. Faisal had a question.
Dr. Faisal, oh, brilliant.
Why does he think phase 1 is a prereq for phase 2 and 3? And plus, big thank you. This was super useful for.
Why, so Dr. Sohail, why do you think a phase 1 is absolutely, thank you.
Am I audible?
Yes, you are.
Just want to say a big thank you. This was super useful for university leaders, and I love the candor que aapne sara kuch laid out here. I think there's so many things different people can take off. And a quick question was, why do you think phase 1 is a prereq for phase 2 and 3? Hope you can expand on it.
Yeah. So I think remember what basically look at the pharmacokinetics of that particular drug and its first in human studies that actually happened. Most of the organizations in the United States who actually get phase 2 and 3 studies are the ones that actually are also engaged and involved in phase 1 studies. So I think it is, for example, I can tell you that not only that it is important for our demographics that we and our genetic profile of our population to actually be engaged in phase 1 studies to understand how our population and we are actually metabolizing a particular drug, disposing its absorption, its metabolism, and its excretion. But it's also the fact that once we are involved in phase 1 studies and once we have gained the confidence of that particular organization, we actually automatically get involved in phase 2 and 3 studies. Number 2, when we are involved in phase 2 and 3 studies, we are actually using the protocol that has been tested in a population that is not Pakistanis. The drug dosage that we are testing, the pharmacokinetics and pharmacovigilance that we are actually conducting is all being the data has been obtained from a population other than Pakistani. So it is important that we have our own data from Pakistan, which actually influences and informs the development of what the dose and protocol would be for these particular studies as we move forward. And I'll give you an example. In my last position, I was in South Texas, which has a little over 90% population, which is Hispanic. Now, that particular population has a very different profile, genetic profile, than the Caucasians or African Americans. And what we learned was that when we did cardiovascular stenting for patients who had a cardiovascular event, 20% to 30% of these, and all of these patients actually ended up getting a printed prescription to take blood thinners and also to take aspirin. And what we realized was that, so many of these patients, about 20 to 30%, would have complications. They would either have the blockage of the stent or they would have bleeding. And there was a continuously revolving door in our ER, which was a trauma level 1 ER to managing these patients. So we did a genetic study and we found out that 20 to 30% of Hispanics actually do not have an active SIC2 or a overactive SIC2 enzyme. And the drug that was being used was actually an inactive drug which had to be converted by SIC2. So you can just imagine that if we would have continued giving these patients from the data that we had obtained from other sources, if we would have continued to give these patients the same inactive form of blood thinners without doing a phase 1 study or a personalized medicine study for this, it would have been very difficult. So I think it is important that we get engaged in phase 1. We have established one in Dow. I'm sure there are other institutions in Pakistan who also have phase 1 units, and we would love to work with you in bringing phase 1 studies as long as you can actually provide the data and in a format and do all the things that we have mentioned in my conversation.
Thank you very much, Dr. Sohail. Any other questions? No? With that, I'd like to ask Dr. Saeed as chair to wrap up this session, and thanks to all our speakers who were online.
Thank you, Dr. Saeed. Always great to learn from you. We are on the committee, Dr. Committee as well. It was an excellent presentation from you, and thank you, Dr. Amir, for explaining about the liquid biopsy in the clinic and the lab. And then we have a presentation from Dr. Shabana and Dr. Amreen. So a wonderful presentation. I think it's quite late, so I won't take much time. And thank you very much that stayed with us till this late. And I'm once again thankful to all the speakers and presenters. Thank you.
Sorry, sorry guys, we just need 5 more minutes. We have the shields and the certificates. Although we can't give them physically to our presenters online, we're going to try our best to send these through some means. PAP is going to do that. But Dr. Rana this morning, we had to give her the award for your shield and your certificate for chairing the session this morning. So Dr. Saeed, would you do the honor? I know, how could we miss this? Yes. Thank you so much, Dr. Rana. That's great. Thank you very much. Dr. Saeed, you get another certificate and another shield. Ah. You can make a collection. Okay, so yes, yeah, who else is here? Start. You're here. Please do the honor. Thank you. So I can ask you to stay there because now we need to do the reverse. Dr. Saeed, you need to give shields to Dr. Shabana Shahid, are you? Okay, you're here. Thank you so much for your presentation. Thank you for coming down from Islamabad. We're delighted to have you here, and Dr. Saeed will do the honors. Great. Thank you very much, everybody, for being so patient and sticking with us until the end. We have a very quick AMPP meeting, so if anybody wants to stay for that, we're just going to be discussing some things about AMPP and what we plan for 2024. So if you'd like to join us for that discussion, please stay. Otherwise, everybody's free to leave. Thank you.